Zero.
Good afternoon. This is Dr. John Bennett broadcasting from sunny Miami. Today we have an exciting day. It's the first online neurosurgical journal club, an idea proposed by the current speaker today, Silky Chotai, MD from India, and now at Vanderbilt, a fellow in spine surgery. And we're going to have a discussion today about steroids and spinal trauma, and we're joined by a distinguished group of panelists. First, we'll introduce the panelists before we turn it over to Silky. Good day, Dr. Farouk.
Yeah, good day. Very nice to see you.
Could you please tell where you're at and what you do, etc.?
Yeah, I am a very, in other words, a young neurosurgeon who is within 1 year of passing the final board exam to practice the neurosurgery. So currently a general neurosurgery practice. I do cerebrovascular in my practice. I am a affiliated neurosurgeon doing for a children's hospital as well, doing a pediatrics there. And currently, I am basically a senior registrar at Bolan Medical College currently. So my practice is basically a general neurosurgery. I do everything.
Great.
Like a general, yeah. I run after everything as a general neurosurgeon.
That's great. And Mohammed, welcome, Mohammed.
Hello, welcome. I want to thank you about giving this opportunity.
Great. And
I'm originally from Iraq and practicing in Yemen. I'm also a young neurosurgeon.
Great.
Just like Farouk.
Great. And Mohammed has a very active group in WhatsApp.
Yes, that's right.
Great. Okay, welcome. And Simon. Hello, Simon.
Hello, everyone. Thank you very much for inviting me here. I'm a medical student in Japan, a neuroscience enthusiast. It's my dream to become the world's oldest neurosurgery resident.
Welcome, Simon. Okay, Silky, could you get off the screen there so we can see you when I introduce you, please?
Oh, yeah.
Okay. Just a second. And this is Silky Chotai. Welcome,
Hi.
Silky.
Hi, everyone. My name is Silky, and I am basically a neurosurgery trainee, a long-time trainee, I guess. So I graduated from India. I had my basic training in China. I worked in South Korea for a while, and then I have been working here in US for a while now. And I'm currently a spine outcomes research fellow at Vanderbilt. And yeah, that's it.
Okay, welcome. And it was Silky's idea to have this, and I really appreciate her coming to me and putting forth the idea. Okay, Silky, it's all yours.
Awesome. All right, so hi everyone. So the idea of journal club, as you might know, journal club is basically a group of people who meet like periodically to critically evaluate published literature regarding the topic of their interest. The reason I came up with this idea is I feel like with the rapidly increasing publication, I mean, the number of publications you see on PubMed are like increasing crazily. And also rapid exchange of healthcare across the globe, there needs to be a common language and common evidence-based treatment that all neurosurgeons use. And we are like very fortunate really to have people like Dr. Bennett, who is very enthusiastic and tech savvy, so that we have a platform where we can share our ideas, have some discussions, and come up with a common, we hope to come up with a common evidence-based practice treatment paradigm for common neurosurgical problems. So using his expertise and based on our ideas, we are trying to have like a monthly journal club where we will discuss, all basic common neurosurgical issues and common literature, or the most published or most cited literature for that topic. So this time, like to start with, I thought we should start with a very basic topic, that is use of steroid in acute spinal cord injury. So as some of you know, that acute spinal cord injury involves a primary injury to the spinal cord that is because of the mechanical forces, which then triggers a secondary response. The primary injury is primarily because of impaction or compression. But within minutes, this is followed by complex events, cellular events, and molecular forces leading to secondary injury. Secondary injury is primarily characterized by ischemia, edema, neurogenic shock, so on and so forth, but primarily because of cellular and molecular forces. So the question comes here is why steroids in acute spinal cord injury? So having known the pathophysiology, we know that secondary injury is the primary event that can be controlled to help these patients. So steroid theoretically, by their mechanism of action, they prevent secondary injury to the spinal cord primarily by improving the spinal cord blood flow. Multiple animal studies have shown that steroids restores impulse transmission, normalize calcium metabolism, and enhance functional neurological recovery following spinal cord trauma. Steroids also inhibit lipid peroxidation, which is one of the most important mechanisms associated with secondary injury to spinal cord. So based on this idea, National Acute Spinal Cord Injury Study, or NASCIS, put together a set of trials to show that these studies, the animal studies can also be replicated in human. So NASCIS group was basically founded in late 1970s. It included 9 hospitals in 7 states in US. And as we discussed, pre-NASCIS steroids were used in management of spinal cord injury just based on evidence from animal studies. So they published 3 series of paper in 1980s and 1990s. And then they demonstrated some evidence that steroid would improve long-term neurological outcomes. And based on this study, until now, across the world, people are using steroid just based on this evidence or some evidence that steroid can improve long-term outcomes. There were a couple strengths of this study, and those strengths were this study, all the studies were prospective study, randomized study, double-blinded, and multi-center. So these 4 things are like combination of things that you need to have a level 1 evidence for any topic. So these were the like primary strength of this study. Going forward to NASCIS 1 trial, so this was published in early 1980s, and what they did is they evaluated 2 types of steroid or methylprednisolone regimen in about 330 patients. First one, they gave 100 milligram bolus, which was followed by 25 milligram every 6 hours for 10 days. And the second group got 1000 milligrams followed by 250 milligram every 6 hours for 10 days. They then followed the patient at 6 weeks, 6 months, and 1 year after injury, and they found there were no significant differences between the 2 regimens in neurological protection. They did find that the incidence of wound infection was significantly higher in high dose group. So overall conclusion from this study was that steroid should not be used, or steroid does not confer any additional protection in patients who have acute spinal cord injury. They came up with NASCIS 2 trial, which was again a randomized prospective multi-center trial. They changed the dosing and regimens. So they divided the patient into 3 groups. First group received methylprednisolone 30 milligram bolus followed by 5.4 milligram per kg per hour for 23 hours. Second group received naloxone and third group received placebo. Again, there were no significant differences in motor or sensory improvement at 1 year. And there were no significant differences in complications. But they did a post hoc analysis. So for some of you who are not aware what is post hoc analysis, so post hoc analysis is something that we do when we did not set out to find that difference. But like in the middle of the study or at the end of the study, we realize that, hey, we also want to look at some subgroups. That is when you do post hoc analysis. So they did, as they did not find any significant difference in their primary outcomes, they did a post hoc analysis, and they found that patients who were treated within 8 hours of injury had significant improvement in motor function. But this improvement was just statistically significant. meaning the p-value was less than 0.05. There was no mention of any clinically significant improvement in the study. There have been a lot of critics of this trial where investigators were contacted to reproduce the data, investigators were contacted to reproduce the statistical methods, and investigators were contacted if they can provide the data that somebody else who was not involved in the trial can redo the analysis. But still, the significant improvement that they noted in the NASCIS 2 trial was not reproduced. Also, the cutoff of 8 hours, which they claim to be significantly different, was based on the fact that the 8 hour was chosen based on the median time to improvement. Again, like it might change in different set of people, in different set of population, in different geographical location. So those were the critics of NASCIS 2 trial. However, for a long time, people followed that patients who were treated within 8 hours of injury might improve significantly compared to those who were not treated with steroids within 8 hours of injury. Because of the critics, they came up with third trial, that is NASCIS 3. They added more patients, and the design was different, where they started the loading dose of methylprednisolone was given 30 milligram per kg within 8 hours. And then the patients were randomized into two groups. One was steroid 5.4 milligram for 23 hours, and second was steroid for 48 hours. They also added a new group of drug, that is non-steroidal drug. The effect of that is again not proven in the management of acute spinal cord injury. Overall, the outcomes were not significantly different between three groups. So they again did a post hoc analysis, and they figured that among patients who received bolus dose of steroid more than 3 hours after the injury had significantly greater improvement compared to patients who did not receive bolus dose within 3 hours. Again, this difference was only significant at 6 weeks and 6 months after surgery, after the injury, not at 1 year or at longer time. Similarly, the cutoff was chosen based on the median time, again, which could be different for different set of people, different set of hospitals, and different geographical location. So these studies were criticized a lot, and a good number of neurosurgeons, orthopedic surgeons practicing spine came up with a number of studies that demonstrated there is no effect of no benefit of adding steroids in acute spinal cord injury patients. So the argument then was, okay, steroids are not useful, but are they harmful? If they are not useful, we can still continue using them. CNS, AANS, so Congress of Neurological Surgeons and American Association of Neurological Surgeons, they did a systematic review of literature and came up with evidence-based guidelines where how harmful the steroids are. So there is class 1 evidence that administration of steroid is significantly associated with higher wound infection, hyperglycemia, and GI hemorrhage. So GI hemorrhage is something that is, as most of you are practicing neurosurgery, you know that patients who have trauma or who have acute spinal cord injury are at higher risk of getting GI hemorrhage to start with. Addition of steroid would deteriorate that, right? So that is the class 1 evidence that steroids are harmful. Class 2 evidence is again that steroids are associated with significantly higher risk of infection, not only wound, but urinary tract and respiratory tract infection and steroid-induced myopathy. Class 3 evidence suggests that there is a significant association of using steroids and development of pneumonia, respiratory failure, peptic ulcer disease, again GI hemorrhage, and hyperglycemia. So overall, steroids are associated with multiple complications. And when we have class 1 evidence of wound infection, hyperglycemia, and GI hemorrhage, those are significant complications. And so the bigger question now is, why debate use of steroid versus not use of steroid? And most important thing here is based on like confusing patterns of confusing evidence in the literature, meaning randomized control trial studies that were prospectively done at multiple center shows that steroids were significantly helpful, and then multiple other studies showed steroids were not significantly helpful and they were harmful. So this led to erratic practice pattern across the globe. So based on that, in 2014, members of US-based Cervical Spine Research Society conducted a survey. They sent out survey questions to all the surgeons who are practicing cervical spine related cord injury. The results were that about half of the surgeons still use steroids to treat cord injury. Of those half, 26% believe that steroids improve neurological recovery. 19% use steroids because of their institutional protocol. And 26% use steroid because of fear of medical legal reasons. Overall, of those surgeons, about 71% had first-hand experiences of complications with steroid use. All of the surgeons recognized certain contraindications of administration of steroid, that is sepsis, GI bleed, and presentation more than 8 hours after injury. Again, we just discussed how the number 8 hour came into practice. That is just based on NASCIS 2 trial, and that is based on median time in their study population. So even after recognizing the harmful effect of steroids, and even after recognizing that steroids may or may not add any added beneficial any added benefit to the treatment of acute spinal cord injury, surgeons as of 2014 have still been using steroids. Similar trend of percentage of using steroids have been found across the country. Have been published from countries across the globe. And finally, CNS-AANS guidelines for use of steroids based on all this research are: the neurological recovery benefit of steroids when administered within 8 hours of acute spinal cord injury has been suggested but not convincingly proven. Administration of steroids for 24 hours has been associated with significant increase in severe medical complications. There is even more striking evidence for severe medical complication when use of steroids is done for more than 48 hours. Overall, the available medical evidence does not support a significant clinical benefit from administration of steroid in the treatment of patients after acute spinal cord injury for either 24 hours or 48 hours duration. Finally, the level of evidence based for this recommendation is level 1 evidence, and that is based on systematic review and meta-analysis, where CNS-AANS suggests that methylprednisolone should not be used for treatment of acute spinal cord injury. There are no level 2 or level 3 evidence to state this, but level 1 evidence suggests that steroid should not be used. And I'm open to discussion. Thank you.
Thank you very much, Silky, for an excellent presentation. And we'll open it up, and of course, we'll concentrate on the neurosurgeons first before. I'd like to introduce Slaven. Slaven came late. Slaven Gločević, a medical student from Croatia. Hello, Slaven.
Yes, hello. I hope my connection is okay. I am.
Okay, it looks good. Okay, Slaven, and we're going to open it up to questions, mostly from the neurosurgeons. So, Mohammed, would you want to comment on Silky's presentation, please?
Okay, definitely. Very nice presentation. I think she put it in a wonderful way to explain that the problem with methylprednisolone, it's complication. It's evidence without evidence of benefit from it. There are some points I want to talk about.
Yes.
In our practice in Yemen, we have like roughly 90% of neurosurgeons are using steroids for acute spinal cord injury.
Okay.
Um, going either with the previous studies, or because they thought that it is of benefit for the patient.
Okay.
We have a dilemma with the acute spinal cord injury is an ugly injury. Very
Yes.
ugly. If you are practicing, you see a patient with a major neurological deficit, you want to do everything to make him
Yep.
better. I think all of those who use steroids are thinking that way.
Yep. I agree.
Yeah, I think with this problem should be more tested.
Yes.
The benefit of corticosteroids should be more tested.
Okay.
Either on animal studies, either on major study, more studies. Because if there is benefit from steroids, you know, you might risk an infection, you might risk a pneumonia, you might risk some controllable complications.
Yes.
With the hope that this might benefit the patient.
Yes.
Because walking again is it's the patient's life.
Yeah.
You know what I'm talking about.
I agree. Yeah.
I only advocate a strong not use of steroids in penetrating spinal injuries.
Yes.
Because definitely there will be a complication, and definitely there will be no benefit. I think it's my opinion. I don't know if you agree with me on that.
Got it. So, do you use like steroids for all non-penetrating?
No. For non-penetrating injuries, I usually it depends.
Okay.
I'll be frank with you. It depends. If I see like a major problem in the spine that I think it will not benefit, like multi-level intramedullary cord injury, like traumatic.
Yeah.
I usually don't use, and when I use when there is some functional still around in the patient.
Yes.
And I usually tell them about the complication.
Yep.
And that there is it is only evidence complication, but no evidence of treatment. We could try if they want.
Got it.
Usually I go with the young patients.
Yep. Agreed.
If patient is diabetic, if patient has already more injuries, I don't risk it.
Got it.
Yes.
I think that makes sense because most of the complications that have been reported are in patients more than 60-year-old.
Yes.
So yeah, and then also I think the practice patterns are very different in developing countries and developed countries.
Yes.
So
we have more
freedom.
We have more freedom. Yes.
Yes.
But it is it is a weapon, should be used and good for people.
Yep.
Yeah,
I agree. Yes. Yeah.
I propose something. If you agree, why we don't we start a multi country study about this?
Yeah, I think that's a great idea, but I think the start would be to have a survey. We can build a survey first and then see what are the practice patterns throughout the, through how many countries are willing to participate.
Yes, you could lead this.
Yeah. I mean, we can replicate the surveys that has been used in past with their permissions, but that would be great idea because I completely agree when a patient comes in ER in a developed country, we have different set of availability resources that we can use. And when a patient come in ER in a developed country, we have different set of resources.
Yes, I know. Yeah. I know, but we could reach an agreement.
Yep, I agree. Yeah, I will put together a survey and then reach out to all of you and see what you think.
And I think functional functional status of the patient prior should be tested,
I agree.
like for complete or only sensory or only motor or the kind of syndrome the patient had.
Yes, I
Okay.
agree. That's a great idea. Thank you so much.
You are most welcome.
Yeah. If Farooq, do you have any comments? Yeah.
Yeah,
Go
Dr.
ahead.
Mahood, do you have any comments or questions? Recently board certified? You're muted. You're muted, sir. Dr. Mahood, you're muted. You're muted. Can't hear you. Can't hear you. Oh, he doesn't know he's muted most time.
Yes.
Unmute.
You can unmute him. You can unmute him.
Oh, I can. Okay. Yeah.
Is it okay now?
Yeah.
Yes. Go ahead.
Can you hear me?
Yes,
Yes,
we can hear you.
can. Yep.
Yeah. Okay, great. I really thank you, Dr. John and Dr. Silky, for having such an idea and making it a very great food for thought, however. And I would like to say a few things about the steroids. The steroid basically has been investigated a lot, taking it from an epidural steroid injection, then putting the steroid injection around the nerve root to prevent the fibrosis, like most of the surgeons. These all are basically have been investigated, and they probably yield no result. But here comes the spinal cord injury, which is a big problem. And we know that the steroid has a scavenging effect. It is an antioxidant, and it is like, it prevents the neutrophil, chemotaxis, and stuff like that. So it is a very strong anti-inflammatory agent. Why we are so interested in steroid to continue our resources to go after the steroid, although it has been proved that it is so harmful. I will give you a couple of my personal example very recently, that this is so, even if there is a benefit, there should be a risk benefit ratio for each patient in terms of the steroid, especially IV steroid, which we inject in a very short period of time in a patient who is having an upper cervical injury and is at risk of aspiration pneumonia, and his is basically the respiratory reserve is very low, the chest expansibility is very low, and these patients are very at high risk, and their phrenic nerve is probably not working if it's a higher level injury in the spinal cord. The NASCIS 1 and NASCIS 2 has done a great idea. Basically, they went for it. I think that is enough, and that doesn't yield anything. And believe me, that doesn't yield anything in my personal view. And most of the neurosurgeon would agree with me that if a steroid is injected in any acute trauma, it is basically harmful. I like the meta-analysis which has been taken very recently by the AANS and CNS, and very thoughtfully should be the end of the story to these steroid use, because we cannot afford. We have so many other things we don't know about. Why don't we go to other aspects of this, other resources? Why not? Why don't we go to, for example, put our energy and cost into other very excellent projects? Let me give you a few examples. We had a patient who was basically a 62 years old. He was a ground level injury and injured a odontoid process which retropulsed back into the spinal cord, and had a ACR2 impairment, basically ACR2 grade, which we grade the spinal cord injury. So what we did, I was basically in my chief residency here, and one of the junior residents evaluated that patient, and they went for, although we don't give the steroid from that point on to any patient, and that patient received a high dose 8 hours protocol for NASCIS 2, that post hoc analysis which already showed that the if we dichotomize the patient into subgroup, even that didn't yield anything for the steroid. Even that small amount of the significance, I don't know what was that significance that has never been to date evaluated by anybody. What was the level of that the significance was that group, and how did it improve the outcome, the final outcome? So anyway, leave that one. Then we had this patient, and after injecting the steroids, within 8 hours, this patient went into a respiratory distress and went to aspiration pneumonia, and the culture came out to be positive, a very resistant organism. And that patient went on to a ventilator where he never came in. We use in my practice since that day. We had a couple of other examples. The steroid has been very notorious for its side effect, especially in the elderly people and higher spinal cord injury level,
Yeah.
especially the cervical spine, because that compromises the chest and other stuff. And about its GI, almost always I have seen each and every complication of the steroid in the setting of the acute trauma. The spinal cord injury is a major trauma. It is a big stress. If we look at pathophysiology of this thing, we already have the robust amount of steroid in our blood, the cortisol. So if we give the exogenous, what is the advantage of doing something? Are we really having a cortisol deficiency to prove that we should fight it against? Let's correlate this thing with the Addisonian crisis in a pituitary apoplexy. In apoplexy, the problem becomes the acute sudden onset of hemorrhage or necrosis in the pituitary that disables or shut down the pituitary. As a result, we have low amount of the steroid, and we give the steroid. The patient wakes up.
Yep.
Within 7 days, and within 7 days, we then go for the surgery and just remove a small amount of the. We all have noticed that in our practice. So if we give the steroid, if the steroid has some beneficial effect, it will speak out. It will come like this. I mean, in my opinion, having a steroid, if it is really working, if it is the real indication of the steroid, there will be no controversy. In my opinion, we should probably stop the practice of the steroid if there is. I don't know what is the medical legal implication of this one, because they probably have a different setup. And here we have basically a very strong evidence that the steroid, rather than having some benefit for the patient, is basically harmful. And I would suggest that we should go and write something about the steroid should not be used. The title of that paper should be the steroid should not be used in acute trauma setting, especially in the spinal cord injury, which is a higher level. This is what I had to say. That's it. And I thank you for this debate once again, coming to our to our neurosurgeon and all that. And I am really in disagreement based on the evidence as well as my personal experience and the effect of the steroid, which we have so far known, against the steroid. So my final conclusion is I will never use the steroid in acute cervical spine injury till my if something comes. Okay.
Yeah. Hey Farooq, thank you so much.
Thank you for the time. Thank you for listening.
Yeah, thank you so much. That's those are some good points. I had one question for you though. So do you never use steroids in any of your spinal cord patients, or do you weigh in the risk benefit for each patient?
No, we look at the rather Silky, just one moment. Look at the side effect of the steroid and look at the advantage we don't know.
Yep.
So if we start off with this equation and look at the level 1 evidence, which basically has come out, the only level 1 evidence we have so far is that meta-analysis, which is the strongest point in my opinion, is the only available evidence, and I am so much agree with that evidence based on the steroid. Look how many side effects of the steroid we know so far. GI bleed, respiratory compromise, respiratory distress syndrome, aspiration pneumonia, poor wound healing, and low immune system, suppression of the pituitary axis. In this dose, the adrenal axis is really shut off. The dose which is basically recommended by the NASCIS 2 is basically shuts off the pituitary or own pituitary. So it becomes very difficult even to wean these patients from the steroid.
Yep.
For some minimum. So there are 7 disadvantages, in my opinion, that are much more applicable for a spinal cord injury, and there is no single advantage so far. Based on this thing, why should we give the steroid? I mean,
No,
what
I
is the
completely,
point?
yes. Thank you so much, Farooq. And I completely agree with you. And, you know, based on the CNS, AANS guidelines, steroids are not recommended and should not be used. But my question to you is like there are some people who still use steroids and they have some justification for that. So my question to you is, do you use them at all or no? No.
Not at all. Farooq, Dr. Farooq, do you use them at all?
We don't give it.
Okay.
We don't use it at all in
Got
the
it.
spinal cord injury.
Okay.
We have stopped
Yeah, so
epidural
that is-
injection for the lumbar stenosis and stuff like that.
Yeah.
We have
So that
stopped
is in
it
line
like
with what we, yeah, that is in line with the CNS, AANS guideline, and that is great. Yeah.
yeah. So not only this guideline is based on a solid facts.
Oh yeah,
So
no doubt about
that's
it.
based on
Yes.
a solid fact. We know too many side effects of the steroids, but we don't know a single advantage for a spinal cord injury. This is what spinal cord injury is not an autoimmune disease, so steroid will not work here for the sake of its anti-inflammatory effect. I don't know if that works in case of the nerves, because I don't know. Basically, I don't really know. And looking at its other end of the steroid, which it has in every single patient, it really disturbs the homeostasis of the patient who is already very disturbed. Use some medication. Yeah, I'm sorry to speak a little bit more. I'm really sorry. And I thank you all for this.
Well, thank you. You're welcome to be here. One quick question before Simon has a question, but one quick question to both, to all the neurosurgeons. What percentage would you say of neurosurgeons in today's world use steroids for acute spinal trauma? A guess. What percentage would you say? Dr. Chotai, what would you say?
I think like it depends on where you are practicing.
Yeah.
If you like speak of US, nobody use steroids. I mean, that is the recommended guidelines. But
against it, okay.
I completely agree with Mohammed. When you are practicing in a situation where you don't have much resources available, people still use steroid. I mean, it's hard to put a number on that, but I think that's the reason we need a survey.
Okay. How about you, Mohammed? What percentage would you say of neurosurgeons in Yemen use steroids with acute spinal trauma? Approximately.
I think too much. I told you before.
Yeah.
It's almost 90%. When you 90%. Told them, I think like this. Even when you discuss with them like steroids should not be used, there is some all teaching and experience that they advocate the use of steroids. I agree with Dr. Farooq of what he said. That's why it should be tested more to know if there is really a benefit or not. And if there is benefit, it should be used in highly selected patients.
Dr. Farooq, what percentage in Pakistan would you say of the neurosurgeons use steroids in spinal trauma? Approximately, what would you say?
Yeah. To be very honest, none of them I have seen, I have talked to. None of them use so far the steroid. On and off, I mean, in some of the practice, which is basically a private-based practice. So institutionally, nobody uses it. The steroid is basically gone, I think, in Pakistan. And I think the statistic is basically in US, it is 26% drop, right?
Okay, very good.
Simon. In US, none here.
Okay.
So basically, nobody uses it here.
Very good. Thank you. Simon, you have a question?
Yes, thank you very much, Silky, for your presentation. I'm learning a great deal from listening to everyone. My question is regarding the second study of neurological function 1 year after spinal cord injury, where no differences were found, but they did refer to animal studies, and they said that the majority of animal studies did find improvement. And I was wondering, what can we extrapolate from animal studies, anything? They were saying that they dropped the weight on the animals in order to cause the injury. So what can we learn from animal studies, if anything?
I think like animal studies, So the way in NASCIS too, the way they created, the way they are describing the animal study is how they created a spinal cord injury in a mouse model. And that is like they drop something on the mouse model and then create a spinal cord injury. Once we have the primary injury, we will wait for a couple minutes and then introduce steroids and see if steroids would increase the blood flow. I mean, the primary mechanism of action of steroid here is to increase the blood flow or to maintain the perfusion pressure, right?
I see.
So that is what we can. The only thing that comes out of the animal study is yes, steroids helps in maintaining the perfusion pressure in the spinal cord.
So it is helpful, but not.
Yeah, that is helpful for sure. Yeah. And then there are a lot of things that can be done going forward to see not only steroids but what are other options that can maintain the set perfusion pressure. Because like if you are practicing in spine, you know that the only thing that you can do to help this patient is to maintain their perfusion pressure, right? If you can maintain the perfusion pressure, you buy enough time to take the patient to OR and decompress the spine.
And that's regardless of it's penetrating or non-penetrating.
Exactly, yeah.
I see.
But to Muhammad's point, I mean, it has been proven over and over again that in penetrating injury, steroids does not help.
Yeah.
So in penetrating injuries, there is no question. It is out of question. But for non-penetrating injury, there has been like umpteen number of papers showing that steroids does not help. So, but still, some surgeons prefer to use, or they have to use. I would still use the word they have to use. They don't prefer to use. I mean, everybody knows that what are the evidence guideline, right? But when you are practicing in certain kind of setup, you have to use steroids. And I think the goal of this journal club one was to identify the strengths and limitations of NASCIS trials, to go over the CNS AANS guidelines, and then to like figure out why still certain, like for example in Yemen, like 90% of population, I mean 90% of surgeons would like to or would have to use steroids, right?
Now, regarding that,
like for like in anything, any kind of research or any kind of treatment paradigm, it has to be like patient specific. It cannot be a yes or no answer, right? It has to be patient specific. It has to be a practice specific. It has to be surgeon specific.
I see.
So,
you did mention also that some surgeons are afraid of being sued.
Yes. Yeah.
And is this happening?
Really?
Not in the U.S. Yeah, this is a concern. And why are they continuing this? That must be based on some case law or some standard that they're trying to follow. Is this not in the U.S.? Is this in developing countries?
So no, that's not the case. The thing is, because the NASCIS trial are the strongest trial as yet. Like they are randomized, they are prospective, they are multi-center. And so that is the reason that whatever results they have, conclusions that they have put forward since 1980, like people still follow that. People still believe that.
Oh, I see.
I mean, that is out of date. It should be like, and then multiple authors have tried to show that that is out of date. The conclusions are way too inflated. I mean, if in their study the median was 8 hours, that does not mean that median 8 hour would be beneficial to all the patients throughout the world. But it has been like inflated and extrapolated more than it should be.
I see.
So I think that's the reason that, people are afraid of being sued and start using steroid.
I see. Thank you.
Was giving steroids the standard of care at one point in neurosurgery?
Yes.
And when did it change? When did the feeling start to change? When the study came out?
Yes, so it was like basically before 1980,
Yep.
Neurosurgeons were just using steroids based on animal results.
Mm-hmm.
After 1980, the NASCIS trial came out and they have like the level 1 evidence that yes, go ahead and use steroids. They are beneficial to your patients. Mm-hmm. So people started using them, and like over the period of 20 years, there were like multiple papers showing that steroids are not useful. So AANS put together a systematic review and meta-analysis where they showed that based on all the evidence so far, including the 1980s NASCIS trial, steroids are not useful and should not be used. Mm-hmm. They also went ahead and said that steroids may be harmful. But like, it is very interesting if you read those guidelines. They have also said that two lines suggesting that if your institutional protocol includes steroids, you can follow the protocol. I mean, the recommendation is to follow the protocol. I think the only thing we can make out of it is because these studies are primarily done in developed countries. So like Germany, most parts of Europe, and then US. So results from this study may or may not apply to developing countries.
Okay.
So I think like that is the reason we are finding a lot of differences in how surgeons practice throughout the globe.
Okay, I think Slaven may have a question. Slaven, can you hear me? Can you hear me okay? You have to unmute if you want to ask a question or give a comment. Well, I don't know if the connection is not too good, Slaven, there. Okay, go ahead, Slaven.
Yeah, okay, can you hear me?
Yes.
Okay, I wanted to say that I think this is a very interesting presentation. I read the articles that forward, so
Sorry.
very interesting and very good.
Okay, Slaven, I think we're not getting the question. I guess we'll have to postpone that. And we could email it to Silky, and she could probably email you back. So, well, sorry, Slaven. Well, I'd like to thank everyone for coming out, especially the neurosurgeons. Thank you, Silky, for putting the effort in, and thank you for the initiative to start this series. And we'll look forward to your talk next month. What is the talk? What is the talk next month?
I think next month is a little easy talk that is about steroids in brain injury, like traumatic brain injury. There is not much controversy there, so it will be like easier than this one. So,
Great. We will look forward to that, and thank you, Mohammed and Dr. Mahood, and Marco. Thank you, and Simon, and thank you all for coming out. So we'll end this broadcast, and you're welcome to stay. Thank you very much.
All right, thank you.